Roughly 1 in 8 American adults currently takes an antidepressant, and psychiatric medications collectively represent one of medicine's most widely prescribed and most widely misunderstood drug categories. Understanding what these medications actually do at the level of brain chemistry and what they cannot do is essential for evaluating both their genuine benefits and their real limitations. Selective serotonin reuptake inhibitors, the most commonly prescribed class of antidepressant medication, work by blocking the reabsorption or reuptake of serotonin back into the presynaptic neuron that released it, increasing serotonin's availability and duration of action at the synapse. Despite this relatively immediate pharmacological effect occurring within hours of the first dose, clinical antidepressant effects typically take 2 to 6 weeks to emerge, indicating that the therapeutic mechanism involves slower downstream neuroadaptive changes, including altered receptor sensitivity and enhanced neuroplasticity, rather than the acute increase in serotonin availability alone. Beyond SSRIs, several other antidepressant classes offer alternative mechanisms for patients who do not respond adequately to first-line treatment. SNRIs block reuptake of both serotonin and norepinephrine. Atypical antidepressants like bupropion primarily affect dopamine and norepinephrine systems, and ketamine and its derivative esketamine act on the glutamate system, producing notably rapid antidepressant effects, sometimes within hours, for treatment-resistant depression, representing a genuinely novel mechanism distinct from traditional monoamine-based antidepressants developed over the preceding 60 years. Antipsychotic medications, used primarily to treat schizophrenia and other psychotic disorders, work primarily by blocking dopamine D2 receptors, particularly in mesolimbic dopamine pathways implicated in the positive symptoms of psychosis, including hallucinations and delusions. First-generation, or typical, antipsychotics block D2 receptors strongly, but carry significant risk of movement-related side effects due to unwanted dopamine blockade in motor circuits, while second-generation, or atypical, antipsychotics affect both dopamine and serotonin systems, generally producing fewer movement side effects, but carrying elevated risk of metabolic side effects, including weight gain and diabetes. Benzodiazepines, used for rapid short-term anxiety relief, work by enhancing the effect of GABA, the brain's primary inhibitory neurotransmitter, at GABA-A receptors, producing rapid calming, muscle-relaxing, and sedative effects that provide fast anxiety relief, often within 30 minutes of administration. However, benzodiazepines carry substantial risk of tolerance, requiring escalating doses for the same effect over time, physical dependence, and difficult, sometimes medically dangerous withdrawal symptoms, leading current clinical guidelines to recommend them primarily for short-term or as-needed use rather than long-term daily anxiety management. Psychiatric medications undergo rigorous randomized controlled trials before FDA approval, ideally including comparison against placebo and, where feasible, active comparison treatments, with statistical analysis controlling for the well-documented and substantial placebo response common in psychiatric conditions, particularly depression and anxiety. Critics note that publication bias in psychiatric drug trials has historically been a significant concern, with negative trials less likely to be published, though FDA trial registration requirements implemented in recent decades have substantially improved transparency and reduced this specific bias in more recently approved medications. Extensive treatment outcome research finds that for moderate to severe depression, anxiety disorders, and several other conditions, combining psychiatric medication with evidence-based psychotherapy generally produces better outcomes, including lower relapse rates, than either treatment approach used alone, with medication often providing more rapid symptom relief, while psychotherapy builds durable coping skills and addresses underlying psychological patterns that medication alone does not directly target. Current clinical guidelines generally recommend this combined approach for more severe presentations, while therapy alone is often sufficient and preferred for milder cases. Psychiatric medications work through diverse, increasingly well-understood neurochemical mechanisms, offering genuine relief for millions of people, while also carrying real limitations, side effects, and, for some classes, dependence risks that require careful clinical management. Understanding these mechanisms and their evidence base allows for a more informed, nuanced view than either uncritical enthusiasm or blanket skepticism about psychiatric medication.